So this next 20 or 30 minutes is going to be about ventilator-associated pneumonias. Our objectives here are state the definition of ventilator-associated pneumonia, or better known as VAP, define who is at greatest risk for the development of VAP, and describe effective strategies for reducing the incidence of VAP. As far as the VAP definition, a pneumonia where the patient is on mechanical ventilation for greater than 2 calendar days on the date of the event, with the day of the ventilator placement being day 1, and the ventilator was in place on the date of the event or the day before. And again, we try to get our patients off these ventilators as quick as we can. This is one of the reasons, is because they're subject to getting VAP if we don't. It's no longer an unfortunate occurrence. It's viewed as a presentable medical error by the Institute of Medicine, Joint Commission, Centers for Medicare and Medicaid Services. And beginning back in 2009, the CMS has limited reimbursement for conditions not presented at admission, such as VAP. Many of you all, I don't know if you know it or not, but that's one of the reasons that we take specimens from our children once they're admitted here to see what kind of, if any, infections they're coming in with and such. Causative organisms, early onset, 48 to 72 hours, the first 48. Haemophilus influenza, Streptococcus pneumonia, Staphylococcus aureus, methicillin-resistant E. coli, Klebsiella. Late onset, or after greater than 72 hours, Pseudomonas aeruginosa, Acinetobacter, and Staphylococcus aureus, or the methicillin-resistant version. And most strains responsible for early onset of VAP are antibiotic sensitive, and those responsible for late onset VAP are usually multiple antibiotic resistant, and that statistic hasn't changed a lot, as you can see in recent history. Pathogenesis, bacteria enter the lower respiratory tract via 3 pathways. Aspiration of organisms from the oral pharynx and GI tract, which are the most common causes, and direct inoculation, as well as inhalation of bacteria. And this is one of the reasons why we try to maintain adequate cuff pressures to reduce the risk of a lot of that going down there, and certainly one of the reasons why we do oral care on these patients to reduce the bacterial load also. Who's at greatest risk? Patients who are up for reintubation, patients in supine positions. Supine position is a terrible position to be in many ways, because our takeoffs from our lungs are in different directions. In the standing up position, the posterior basal segments of the lungs are facing pretty much in that direction. But look what happens when you put them in a supine position. It's almost vertical, meaning that kind of stuff can get into the posterior basal segments of the lungs, which is very difficult to get pneumonias out of. Impaired cough and depressed loss of consciousness, level of consciousness. Oropharyngeal colonization, presence of NG and OG tubes, enteral feeding, and cross-contamination by staph. It's important to remember that because a child or an adult has an airway in and the cuff is inflated, that it's not that they're not going to get secretions in the airway. They're going to, but we try to reduce the risk by inflating the cuff and also by doing oral care to reduce the pathogen load. So why do we care? A hospital-acquired pneumonia is second most common hospital infection. Ventilator-associated pneumonia is the most common intensive care unit infection, and 90% of all nosocomial infections occurring in ventilator patients are pneumonias. Ventilator-associated pneumonia occurs in approximately 9 to 28% of all ventilated patients. Again, that stat hasn't changed a whole lot over the years. The incidence of VAP is highest in the following groups: trauma, burns, neurosurgical population, and surgery. Mortality rate is 24 to 50%, and mortality rate in VAP is caused by Pseudomonas or Acinetobacter is as high as 76%. I put these next 2 slides in here to give you a little bit of feel as far as perspective of the costs associated with ventilator-associated pneumonias. medical costs, ventilator days, and ICU and hospital length of stays. Low-intensity treatment for moderate burns may cost $206,000 in excess of that, or more if there are complications. For severe burns treated without complications, a little over $1.5 million, 1.6 million. And with complications, a severe burn can cost more than $10 million to treat. Costs, infections including pneumonia, sepsis, organ failure from infection problems occurring in 35% of the cases adds another $58,000 to $128,000 to treatment. And you can see that those figures were derived back in 2018. These costs continue to go up. How do we diagnose? Radiologic evidence of new and persistent or progressive and persistent infiltrates, consolidation, cavitation. At least one of the following: a fever greater than 38 degrees centigrade with no other recognized cause, leukopenia less than 4,000, or leukocytosis greater than 12,000. And at least one of the following: new onset of purulent sputum or change in character of sputum, increased respiratory secretions or increased suctioning requirements, new onset of worsening cough, dyspnea or tachypnea, rales or bronchial breath sounds, worsening gas exchange, such as decrease in saturations, a PF ratio or a PF ratio less than 240. That's one of the criteria actually for extubating patients. The PF ratio has to be greater than 200. Increased oxygen requirement or increased ventilator demand. And specific practices have been shown to decrease ventilator-associated pneumonia. There's strong evidence that a collaborative multidisciplinary approach incorporating many interventions is paramount. Intensive education directed at nurses and respiratory therapists, practitioners results in a 57% decrease in VAP. So prevention is critical, and as far as intubation, these children or adults for that matter should only be intubated if necessary. Early extubation of criteria is met and patient passes a spontaneous breathing trial, and I went over those a while ago a little bit with you. Hand washing, of course, is important. Oral care, head of bed elevated 30 degrees in the absence of medical contradictions. Patient turning and rotational therapy, which I think we could probably do a little bit more of that in our neck of the woods, but it is done. GI and DVT prophylaxis, and daily interruption of sedative infusions, and airway and ventilator management. As far as hand hygiene, we're all familiar with that. It's the single most important and easiest method for reducing the transmission of pathogens. And we do it before and after contact with patients, beginning and end of the workday, and before and after using gloves, and after touching, of course, contaminated surfaces. As far as oral care, dental plaque contains multiple pathogens. It may include Staph aureus and Pseudomonas aeruginosa. After 48 hours, normal oral flora of critically ill patients changes to a more virulent gram-negative organism. Aspiration of oral secretions around the cuff and ET tube occur in all ventilated patients, whether the cuff's inflated or not. Unfortunately, we get some patients in from other countries who come in intubated with uncuffed endotracheal tubes, which raises the risk for aspiration. Ventilator-associated pneumonia rates are reduced when oral care measures are included in a comprehensive prevention program. So why is there no consistency? Lack of placing high priority on oral care. This is especially true in the first hours or days of critical illness when colonization of pathogens occurs. Anxiety regarding loss of an endotracheal tube, particularly those patients that are orally intubated, especially the ones that have a lot of airway swelling. We don't want to risk the chance of that tube coming out if they jerk around while we're suctioning them and such. That's why it's important to have those tubes nice and secure. Inadequate or inconsistent supplies. So the best practices: daily assessment to determine oral health, the use of oral care kits, brush every 12 hours to prevent plaque formation, oral cleansing every 2 to 4 hours to promote healing and maintain the integrity of oral tissues. Use of an alcohol-free antiseptic, oral rinse to prevent or reduce bacterial load of oral pharynx, and routine suctioning of the mouth to manage oral secretions and minimize risk. It's at this point I want to interject something. One thing that I do notice that happens once in a while, and you really need to be aware of this, it makes me think about fecal oral transmission. I still see in our neck of the woods and in other hospitals where people continually place everything oral between the legs or below the waist, where we clean our children and such. We have to think and realize fecal oral, anything airway, yank hours, manual resuscitators, suction catheters, oral airways, laryngoscopes, everything airway should be above the waist to reduce the risk of that kind of infection. Okay, and the head of bed 30 to 45 degrees, the supine position is an independent risk factor for death in all ICU patients. Why? Again, because of the posterior basal segments of the lungs. They can take up those kind of infections, and it's difficult to get those infections out of there. Major benefit is prevention of aspiration. CDC recommends the head of bed 30 to 45 degrees and thus contraindicated. Head of bed elevation greater than 30 degrees on all mechanical ventilated patients. Contradictions are those who are hypotensive with a MAP less than 70. I think in our neck of the woods, that number is 55 to 60, depending on the patient's age group. Tachycardia is greater than 150. Cardiac index less than 2. Central line procedure. Posterior circulation strokes. Cervical spine instability use. Reverse Trendelenburg. Some femoral lines, like intra-aortic balloon pump, no higher than 30 degrees, use reverse Trendelenburg. Increased ICP, no higher than 30 degrees, avoid hip flexion and proning. As far as patient turning, advantages include better distribution of ventilation, mobilization of bronchial secretions, reduced risk of pneumonia, and reduced risk of pressure necrosis. As far as gastric alkalinization, H2 blockers and antacids decrease the incidence of stress ulcers. Colonization of the GI tract occurs as the pH rises, and these organisms ascend the GI tract and gain access to the trachea. As far as peptic ulcer disease prophylaxis, it is unclear if there is any association between peptic ulcer disease prophylaxis and decreasing rates of ventilator-associated pneumonias. Experience shows that when peptic ulcer disease prophylaxis is applied as part of a package of interventions for ventilator care, the rate of pneumonia decreases. As far as DVT thrombosis prophylaxis, higher incidence of DVT and critical illness. There's a risk of venous thromboembolism that is reduced if prophylaxis is consistently applied. And the target is patients undergoing surgery, trauma patients, acutely ill medical patients, and ICU patients in general. Again, there's an image of a DVT prophylaxis, what we use the prophylaxis for, I should say. DVT prophylaxis, it is unclear if there is any association between DVT prophylaxis and decreasing rates of VAP. I think we did that one already. As far as oversedation is concerned, there's a predisposition to patients to thromboemboli, pressure ulcers, gastric regurgitation and aspiration, ventilator-associated pneumonia, and sepsis. Consequences include difficulty in monitoring the neurostatus of patients, increased use of diagnostic procedures, increased ventilator days, and prolonged ICU and hospital stay. As far as nurse-driven sedation weaning protocols, there's multiple research studies have shown that nurse-driven sedation protocols improve patient outcomes. Routine assessments and response to therapy should be incorporated in the protocol. A sedation goal should be defined for each individual patient. and without a goal, adequate levels of sedation will not be achieved. I think it's safe to say in our neck of the woods they use as minimal sedation as possible to reduce a lot of these risks. As far as continuous infusions and daily wake-up, all infusions should be at the lowest rate to achieve effect. IV bolus therapy should be used to supplement infusion when necessary. And every patient must be awakened daily unless contraindicated. And again, that's usually about 4 o'clock in the morning, and about 8 o'clock in the morning is when these patients are usually ready for extubation. Daily wake-up continuing, wean infusion to off in increments of 10 to 25% daily in order to perform a clinical assessment. And rebolus and restart infusion if the patient becomes symptomatic, and your new continuous IV dose should be lower than what you began with. Again, the goal is to decrease sedation. As far as endotracheal intubation, it contributes to the development of VAP that can cause mucosal injury, producing decreased mucociliary clearance. It decreases the effectiveness of the cough. It increases binding sites for bacteria. It increases mucus secretion and provides a reservoir for bacteria. And one thing that's not mentioned in here is the use of saline with patients who are intubated. We have to remember that saline reduces the effectiveness of some of the chemical that maintains the alveolar patency down there. Reintubation is a significant risk factor for VAP. As far as airway management, mechanical ventilation, oral tracheal intubation, nasal tracheal intubation may slightly increase the risk of VAP. Ventilator circuitry changes. We prefer they be changed every 7 days when soiled or when malfunctioning. And again, cuff pressure, we try to keep those at a minimal. I think generally speaking, we try to keep those cuff pressures below 20. In some extreme cases, we have to have the cuff pressures much higher in patients who require higher cuff pressures, but that is not without risk. As far as the ventilator circuit, the circuit should not be routinely opened once ventilation is initiated. That's one of the reasons we have inline suction catheters in these circuits, so as not to disconnect these circuits as often. And disconnection of ventilator tubing can lead to a loss of PEEP, of course, and alveolar de-recruitment. That circuits should not be routinely changed unless visibly soiled or mechanically defective. In the event of ineffective ventilation, manual ventilation with an ambu bag or manual resuscitate may be used. Expiratory condensation should be removed via the trap in the tubing, and we do have water traps in our ventilator circuits. As far as airway management, inline suctioning using closed suction techniques is what we use. Again, so we don't have to disconnect these patients from the ventilator every time that we need to suction them. I mentioned about normal saline a second ago. The chemical that helps maintain alveolar patency, of course, is surfactant. If you use a lot of saline, you can reduce the effectiveness of that surfactant, which reduces which can lead to atelectasis or microatelectasis. So it should not be used routinely to suction patients. It can cause desaturation also. It does not increase the removal of secretions. It can potentially dislodge bacteria. What do we need to improve on to make secretions thin enough to remove? Adequate systemic hydration. We use the saline sparingly, and if we have to thin secretion, it's like the mucovistin albuterol protocol that I mentioned just a while ago. As far as oral suction devices, and I can't say this enough, keep Yankauer hard tip suctions, any suction, anything airway above the waist to reduce the risk of at least that kind of transmission of a bug, fecal oral. Best practices are change every day, rinse with sterile water or normal saline and allow to air dry. And the Ventilator-Associated Pneumonia Bundle is a package of evidence-based interventions that, when implemented together for all patients on mechanical ventilation, has resulted in a dramatic reduction in the incidence of ventilator-associated pneumonias. And this is the ventilator bundle. I monitor this bundle every month with our therapist to see if there's compliance with regard to oral care and such. And I still see where oral care isn't shown that it has been done. I know you guys do them. I know our therapists do them, but sometimes somebody forgets to document that it was actually done. So please be sure that it is done. In the ventilator bundle, elements consist of elevation of the head of the bed to between 35 and 45 degrees, daily sedation, vacation. Again, about 4 o'clock in the morning, it's important to start backing off of those elements of sedation. Daily assessment of readiness to extubate, peptic ulcer disease prophylaxis, DVT prophylaxis, well, that's contraindicated, and oral care. And the goal is 95% of all patients on mechanical ventilation in the ICU receive all 6 elements of the ventilator bundle. And these are how these things are measured as far as ventilator days and as far as ventilator days and ventilator bundle compliance. So what is our VAP rate? The last VAP documented was in 2011. Most recent one, a VAP in July of 2018. Our goal is 0 per 1,000 ventilator days, I should say. And that process improvement team is really everybody: RNs, RTs, ICCs, pharmacists, nurse managers, and PI director. And that's it. Any questions? Okay. Clayton, you got the floor.